Hello and welcome to Health Chats with Abington Health. I'm your host, Lu Ann Cahn with Philadelphia Magazine. This web chat is sponsored by Abington Health in partnership with Philadelphia Magazine. Our topic tonight is getting pregnant after the age of 35. And we know this is a very hot topic because so many couples and women are deciding to get pregnant at a later point in life. So we hope tonight that you're going to learn about fertility, assistance options for getting pregnant, the risks and benefits for getting and being pregnant later in life. Tonight, we're chatting with Dr. Mara Thur, OBGYN at Abington Health. Good evening, Dr. Thur.
Hi, Lu Ann. It's nice to see you.
It's nice to see you, and thank you for joining us. Before we get started, I want to remind everyone at home that if you have questions during our discussion, you can ask them in the text box right under the video. So don't be shy. This is anonymous, it's confidential, so feel free to ask us whatever you want. And also, please feel free to encourage your friends to join us. You can they can log on anytime during the chat by sending a link. You can send them a link to Health Chats and share that, send them an email or share it on social media. Okay, Dr. Thur, first, before we get started, why don't you tell us a little bit about your background and your expertise?
So I am an OBGYN at Abington. I've been there for 13 years. I did my training there, and I went to medical school at Temple. So I'm a generalist at the hospital, and I see everybody from age 13 to age, into their 90s. So sort of run the gamut: obstetrics, gynecology, a little bit of everything.
We were talking a little bit earlier, and you were saying that in a way, when couples are trying to get pregnant, if they're having problems, you're kind of a gatekeeper. Can you explain that?
Well, we, as a gynecologist, we're the primary care doc for a lot of women. So they come to us for their yearly GYN exams, and certainly when you're into your 20s, your 30s, your mid-30s, this is kind of the hot topic, getting pregnant. It's always on their mind. And if you come to us and are having difficulty, I can certainly start the process of doing that workup if someone's having trouble getting pregnant. And then once we've taken that road for a period of time, and if we haven't been successful, then I can refer someone off to an infertility specialist.
Okay, we have received so many questions in advance, and one of the most basic questions is, okay, you want to get pregnant, what are some things you should do before you even start trying?
So I think generally you want to lead a healthy lifestyle, just like anything else. And you want to make sure that you optimize your weight, that you're eating a healthy diet. And most importantly, we think about things like folic acid, which is oftentimes things that you get in your diet, but it's certainly something supplemental that we would want you to take before getting pregnant. We usually recommend that you take either a multivitamin or a prenatal vitamin for at least 3 months before trying to get pregnant. We want those things on board, and particularly the folic acid, to help prevent against neural tube issues.
A lot of women might be on oral contraceptives before they decide they want to try to get pregnant. How long does it take how long should they be off the pill, let's say, before they try to get pregnant?
Usually tell people that they should be off the pill for about 3 months before trying to get pregnant. There might be some thought that if you get pregnant too early, right after going off the pill, that might increase your risk for a miscarriage. So we usually tell people to wait about 3 months.
All right, and I know a lot of couples or women are thinking about genetic screening. What do they need to know about that? Is that for everyone or just some women?
There are some things that we recommend for sort of the general population across the board. CF testing, or cystic fibrosis testing, is something that we offer to all women. And then, it certainly gets a little bit more specific. Ashkenazi Jewish women, we oftentimes recommend the Ashkenazi Jewish panel, which tests for a myriad of genetic disorders that are more common in Ashkenazi, the Ashkenazi Jewish population. So those are some of the things that we kind of start out with. And then once you are pregnant, then there's sort of a whole slew of genetic testing that we can offer to patients.
All right. And I just want to, again, remind everyone at home that if you have a question right now, you could submit it in the text box that's right under the video box. So I want to move to the topic of fertility, more questions about that. A lot of women would like to know if stress impacts fertility.
No, it's interesting. There's been a lot of studies that look at this, and sort of anecdotally, you would think so. If you lead a very stressful lifestyle, you produce a lot of hormone called cortisol that maybe it decreases your fertility. There's definitely some people say yes, some people say no. It's sort of a little bit of the issue with trying to tease that out is that there's so many other factors besides just stress. And so it's a little bit, it's kind of a question mark as to whether stress really does affect fertility. It's interesting, we were talking about this before we started, that you hear a lot, there'll be couples that have been suffering with infertility for a long time. They finally make the decision to go for IVF and they get pregnant, they have a baby, and then they come to us and they say, oh, I don't need any contraception now that I've had this baby. I've had all of these years of infertility, and then, the stress is gone. They're, wonderfully happy with their new baby, and then poof, all of a sudden they're pregnant and they don't even realize it. So you've got to wonder whether stress does play some sort of a role.
Let's talk about some of the other factors that could really play a role. For example, being underweight or overweight, how could that impact fertility?
Certainly, on both ends of the spectrum, it can definitely affect fertility. And most commonly, when you're underweight, a lot of people stop getting a period. And so obviously, if you're not getting a period, then chances are you're not ovulating. And so it makes it very, very difficult to get pregnant if you're not ovulating and you're not getting a period. Same holds true for someone who is significantly overweight. So sometimes just with maybe about a 10% decrease in weight, people return back to having a normal menstrual cycle. And then the whole process sort of normalizes.
And I know you were saying just a healthy lifestyle certainly helps, but do women need to just stop drinking completely, no wine or smoking, or what would they need to do to kind of optimize their chances?
Sure. I mean, certainly smoking is bad for so many reasons in every aspect of healthcare. Smoking is really something that we encourage people to quit, and that's kind of a given. Alcohol intake, something that we discourage during while trying to get pregnant, during pregnancy, particularly during the first trimester, can increase risk for birth defects. Caffeine, lots of caffeine can potentially increase the risk for miscarriage. But across the board, I always tell people everything in moderation. If you can't stop everything that you're doing once you're pregnant, and you need to live your life and live a healthy lifestyle, but not to an extreme one way or the other.
There are all these myths about different ways you could boost your fertility, stand on your head, all sorts of different things. Is there any real way besides living that healthy lifestyle?
There really isn't any way, as far as I'm aware, to be able to boost your fertility. As we said, really making sure that you're living that healthy lifestyle, that you're, exercising, but not to excess, you're keeping a healthy weight. There's nothing that I'm aware of, no supplements or vitamin that can make you super fertile,
You're sure? Okay. There are so many more options if you're having trouble getting pregnant. What are those options?
So I guess to back up a little bit, when someone comes to us with issues with infertility, we always start out with a complete history. We want to know kind of what your past is, whether you've had any kind of prior pregnancies in the past, what your partner's pregnancy history is, and so you start with a pretty thorough history. And then we do a little bit of blood work, a little bit of baseline testing, just to make sure that all of those things are normal. And then once you've sort of established that all the parts are working, we often recommend that the husband gets a semen analysis, because really, when you talk about infertility, about 40% of the time it's a problem with the man, about 40% of the time it's a problem with the woman, and about 20% of the time it's an issue with both. So even though we focus so much on infertility and having it be the woman's issue, in fact, almost half the time it's an issue with the male partner. So once you've kind of gone through those that testing, and you've sort of gotten to the point where everything looks like it checks out okay, then for me as a generalist, a lot of times we can give oral medication to try and help you to ovulate. And that tends to work really well. Oftentimes we'll give people several cycles of a particular medication, either a medication called Clomid or another medication called Letrozole. They're easy, they're inexpensive drugs that I can give in the office. And then I basically tell people, go have fun. You've taken your medication. You plan to ovulate at this particular time. Enjoy yourself, and then we'll have you come back and see if we've been successful at getting you pregnant.
How long should they wait? Let's say you give them oral, you give a woman oral medication and nothing happens. How long do they wait before they come back and say, okay, we've got to go to the next step?
So, everyone's a little bit different. If you talk to sort of general OBGYNs, and they might have a slightly different approach, but at least for me, I probably give someone maybe 3 cycles of the medication, because it isn't, I joke that I just tell people to go off and have sex. It's not really like that. There's some monitoring. I tell them exactly when to take the medication. Then, they'll go and do what's called timed intercourse, meaning that we tell people to have sex every other day, right around the time they're going to ovulate. And then, they are either pregnant or they're not. And then they'll come to me, I've got my period, Dr. Thur, and then we might try another cycle of that same medication. And then once we get to that point and I've sort of exhausted my means, then I would refer out to a reproductive endocrinologist and infertility specialist.
Okay, and we'll come back again. I want to talk about some of the options that they might have, but we just got a question in from Philadelphia from a viewer who's asking, are there concerns with conceiving with a man who is over age 35?
There might be actually some validity to that we always talk about that scary advanced maternal age, which really, women appreciate when you tell them that they're old, even though they're only 35. But there is something called advanced paternal age, so an older man having children. And there might be some validity. There might be some increase in miscarriage rate when you have an older man having babies. Okay,
so let's go back to talking about what the options might be if oral medication isn't working and you refer them to a fertility doctor. What might a fertility doctor offer?
So the fertility doctor oftentimes will maybe repeat some of the blood work that was done by the generalist, and sometimes they can use oral medication as well. The advantage that the infertility specialist has is that they have ultrasounds at their disposal. Their laboratory is usually very, very accessible, and they're able to monitor patients a little bit more closely than I am. I don't have the luxury of having an ultrasound in my office where I'm able to monitor those people. So oftentimes the fertility specialist will use those means as well. So if those don't work, then oftentimes There's injectable type medication, although fertility doctors seem to be moving away from that because there's a lot of complications. It's a lot harder to control those. So then they move on to IVF. And now even IVF has become very controlled. Oftentimes there's not the same risks of twins and triplets and quadruplets and things like that.
And doctor, if you would explain IVF, what is the basic process?
Sure. So IVF is in vitro fertilization, and the woman is given medication in order to stimulate her ovaries to produce eggs. So the eggs are retrieved, and then the husband or the partner then contributes their semen. They make an embryo in the petri dish in the lab, and then they go ahead and implant those embryos back into mom. It used to be that they would maybe implant 2 embryos, 3 embryos. It really depends. There's a lot of variation in that. But just in talking to some of the infertility specialists, recently they're trying to cut down the number of embryos that they reimplant because the success rates are so high with just 1 embryo that they're trying to limit the amount of twins and triplets and things like that. So,
you know, another hot topic these days is younger women freezing their eggs because they anticipate, well, first of all, that maybe they don't have a partner in the picture and they want to wait. What do you think of this? And at what age would you do that if you were planning?
It's a really interesting question. Fertility and planning your family and things like that is a very personal issue, and people have there's a lot of social aspects to it, people's careers and a lot of influences. So not everybody is ready to have a baby at 25 or 30 or 32, and so people are really planning ahead, and it's a very interesting concept. And I think if you're able to and you have the means and you have the forethought to know, yes, I definitely want to have a baby, then maybe freezing your eggs isn't a bad idea at all. We do know, though, as you age, your eggs age. So I would say maybe the earlier you do it, the better. And it's not as if at 35, all of a sudden you wake up on your 35th birthday and all your eggs are bad. But it's sort of a continuum. So the earlier, I guess, you freeze your eggs, the better.
What is the age where you're generally that eggs aren't as good, or you're not getting as many eggs, let's say?
So again, it's kind of this continuum, and it increases in terms of, because it's a decrease in production of eggs, but it's also, even more importantly, the quality of the eggs aren't as good as you age. And we know that if the quality of the eggs aren't as good, you might become pregnant, but you have a much higher risk of miscarriage. And I would say once you get to, sort of that 40 to 44-year-old range, then the risk of the eggs decreasing in number, but more importantly, not being as good and increasing your risk for a chromosome issue definitely goes up.
Okay. Well, again, I want to remind you that we're taking questions from you right now. So if you're watching and you have a question, just put it in the text box underneath the video and we'll try to get it to Dr. Thur. Let's continue to talk about risks, because there definitely are risks having children later in life to the mother and the baby. Can you talk about that?
Sure. So there's risks to mom during pregnancy. When you are over the age of 35, there is an increased risk for diabetes, for high blood pressure, issues with the placenta. And so those are some of the things that we think about and we monitor older moms for during the pregnancy. So particularly women that are over the age of 35 into their 40s, oftentimes we do additional ultrasounds to monitor the growth of the baby, because sometimes the placenta just doesn't function as well when you're as you age. So that's certainly an issue for pregnancy when you're over the age of 35, just for maternal reasons alone. And then, of course, when you talk about an older mom, there is that increased risk for genetic abnormalities. And so there's a lot of options in terms of getting genetic counseling and what genetic testing is available to kind of find out more about the pregnancy.
And we just had have a question here from Cherry Hill asking again about, does age play a factor? Maybe not so much in genetic issues, but special needs, maybe learning disabilities. Do you know?
Not that I'm aware of. You know, obviously autism and special needs is a hugely hot and very important topic. But to my knowledge, being of advanced maternal age doesn't necessarily increase your risk for autism, as far as I'm aware.
Now, here's an interesting question someone's asked. If I lived a very stressful career-driven life in my 20s and early 30s, will that affect my pregnancy or chances of getting pregnant?
I don't think stress in the past necessarily is predictive of how successful you'll be to get pregnant, 10 years beyond that. It's really your age and all of those other things that we talked about that might increase your risk for, say, miscarriage or difficulty getting pregnant. But stress 20 years ago, we can put that behind you.
Okay. Well, someone's asking, so somebody, you're considered, okay, high risk at age 35. What about 47? Is it just exponentially? Are there more risks, or is it the same?
Well, certainly 47 would be a unique age to certainly get pregnant on your own. Risk of miscarriage with a 47-year-old is probably, at least 50%, if not higher. So those risks really do increase dramatically. And then you just think about average age of menopause is 51. So that means people are on one end of the spectrum or the other. And there are a lot of women that are going through menopause at 47 and are, completely done even having the ability to have children.
So someone is asking, so when is the age that you should really stop thinking about trying to have children? Physically, on your own?
That's a tough one. Again, it's a very personal decision that you make with your family and determine, how many children is enough for you and what your family unit is and all of those factors. So I would never tell someone, you must stop trying at, 40 or 41 or 42. But certainly, as long as everything in medicine is knowing kind of the positives and negatives. So as long as you realize going into it that you might have a increased risk for a miscarriage or, problems with the pregnancy, and you're okay with that, then I don't know if there's really an age limit.
We have a question here. Are there advantages of getting pregnant at a later age?
So that's as far as I'm aware, there's no medical advantage to getting pregnant at a later age, but, you could certainly argue that you're more worldly, you're more settled, you're in a better sort of psychological place in your life. I mean, there's so many factors, but from a purely medical standpoint, I don't know if there's any benefits to being older.
All right, and I've never heard this, but somebody's asking, is it true that women who have children later in life live longer?
So there's definitely some theories on that, and that if you are able to conceive naturally, so not by IVF or any kind of assisted reproductive technologies, that maybe you do live longer. Maybe your aging process, you age slower than someone else of a similar age. But it is kind of an interesting question, but maybe there's some validity to that.
Okay, all right. I want to remind you again, if you have a question, just write it in the text box and I will ask Dr. Thur for you. I do have some very specific questions that viewers have sent in advance. This one is about getting help from medical insurance. She writes, I've been told fertility treatments are not covered by insurance and they are very expensive. If any medical issues have been ruled out, are there any less expensive options to assist? Well, if we could talk about that first. Is that true that fertility treatments are not covered by insurance?
That would be something sort of more specific to the reproductive endocrinologist, but I do know that in the state of Pennsylvania, it's not covered by insurance, or it's only partially covered. Some of the testing can be covered, but oftentimes when you get to that point where you're doing IVF or in vitro fertilization, those sort of things are not covered by insurance. Certain states actually, as far as I'm aware, actually the state of Massachusetts, actually their insurance covers 3 full rounds of IVF completely for free. So unfortunately, we live in Pennsylvania. We don't live in Massachusetts. So it's so as far as I'm aware, the IVF portion of it is not covered by insurance.
And is there one method that works best for women around the age of 35 or older? Like, how successful is the oral medicine that you were talking about earlier?
So the oral medication, there's a couple different types. There's one called Clomid, another called Letrozole. And assuming that everything is working well, success rates can vary. It also depends on whether you have that ability to do something called intrauterine insemination, which is actually when they're able to inseminate or place the sperm directly into the uterus. That's not something that I would do as a generalist, but if you went to an infertility doctor, then they would be able to do that. Once you get into the IVF realm, then success rates are really, they're quoting patients success rates of 60-65%. So amazing. They've done amazing things in terms of, now obviously there's lots of factors in terms of age and other complicating medical issues, but success rates have really they're incredibly high, and it's very exciting for us.
Oh, absolutely. This is a very interesting question. What are the odds of a woman over 35 getting pregnant when her husband had a vasectomy reversal?
Well, that's a good one. That's an interesting one.
I mean, yeah. Is it more difficult? And maybe that goes to how successful are reversals. I don't know. Do you come up? Have you seen that? So
vasectomy reversals, obviously, I don't work on men, but vasectomy reversal would be, you'd go to it would be a urologic procedure. So I don't know exactly what the success rates for vasectomy reversals are, but presumably if it was successful and the husband or the partner is then producing sperm normally and they're able to document that with semen sample, then I think success rates would be just the same as the partner having never had a vasectomy.
So that would be a probably pretty easy test to do, to find out if your chances should be normal. Let me ask you another question from Doylestown. Can I have my fertility levels tested while on birth control? She's talking about FSH and AMH. I think I have that right. Or how long should I wait to be tested once I stop taking the pill?
So you can't have your FSH level, your AMH. Now AMH is your anti-Müllerian hormone, and it's another hormone that we can check to sort of determine fertility. Your FSH level is something called your follicle stimulating hormone. That's how well your ovary is functioning. But so you can't check it while you're on the birth control pill. We usually recommend not checking the FSH level until you've been off the pill at least a month. And then that AMH level, probably at least 2 cycles before trying to check that lab work.
All right, so here's a question. She writes, I waited so long to try to get pregnant that now I'm having regretful feelings about my pregnancy and leaving behind the life that I love. I was very happy before and have not been feeling happy during my pregnancy. Is this unusual? What should I do?
Pregnancy is a very emotional time for people, and I think there's a lot of guilt that moms carry, during pregnancy, postpartum, guilt about breastfeeding, guilt about, everything from the simplest things. So I think that it happens. There's a lot of mixed feelings that people have about pregnancy, and I don't think that the person who wrote in should feel bad about it. And there's certainly counselors, therapists, things like that. We have a ton of resources for people that are having difficulty. There's a lot of people that deal with depression and anxiety and things like that during, pre-pregnancy, during pregnancy. There's a lot of resources out there for someone in that situation.
Okay, and here's a specific question about Down syndrome. Apparently it runs in this viewer's family, and just concerned that there's more of a probability that there would be Down syndrome. Is that true?
It tends not to be genetic, although there could be potentially a genetic component to it. Really, the issue for Down syndrome is that as you age, your risk of a chromosome issue goes up. So your risk for Down syndrome definitely increases as you age, as well as any other type of chromosome abnormality.
All right, another very specific question here. Our viewer writes, I'm 35, have been trying to get pregnant with our first child for 9 months now. I've had some blood work done and they all came back normal. I assume the next step would be to have my husband checked. He's 31 and very active, healthy, non-smoker. Should we give it a few more months before seeking help?
So, if you open the textbook, they'll say a year of unexplained, attempting conception and not being able to. For a year, we call you, we give you that diagnosis of infertility. But my feeling is, when you've made that step to come to your doctor and say, I've been trying for 6 months, I've been trying for 9 months, and I haven't been successful, then it's pretty mean to send someone away. So if I have a patient that comes to me and technically has only been trying for 9 months and they want to get a little bit of a workup, some lab work done, then I'm more than happy to do that. Especially when you're 35. If someone came to me and they were 22 or 23 years old and said, oh, I've been trying to get pregnant for 9 months, and you're in a very different spot in your life, in your reproductive life. So I hope that answers that question. But I would start that process, sure.
Right. What we haven't talked about, and you see this portrayed in movies all the time, that oh my gosh, the couple's sent home to have sex at certain days, certain times. And I know you're saying that stress doesn't have anything to do, probably, but that has got to be very, very stressful for a couple to go through when they're trying to have children. How do you counsel them through this?
Yeah, there's definitely, there's so many elements with that, and, performance anxiety in men. The list goes on and on. But we sort of arm people with the information of knowing, and there's so many apps on your phone. You can have apps as to when your most fertile time is, and it'll ding when you're ovulating. There's ovulation prediction.
Do you like that idea? Do you recommend? That seems, yeah, it's time, ding.
Well, you'd be surprised. People are, when people want to get pregnant, there is nothing.
I'm not surprised. I'm just saying, does this help or not?
Well, certainly, if it's going to tell you when you're ovulating, then you kind of want to you want to get the most bang for your buck. So I always tell people sperm is a lot hardier than an egg. Sperm can live to up to 3 days in the genital tract. So the best thing to do is actually have sex before you're going to ovulate, because the egg only lives for 24 hours. So you kind of want those sperm waiting there when the egg gets released to give you the best chance of getting pregnant. So by doing an ovulation predictor kit that you get from the pharmacy, it tells you kind of your most fertile time, and then you know when to concentrate your energy.
All right, we just got a viewer question from Philadelphia. It says, my mom took Clomid, the fertility drug Clomid, in the 1970s, and then was diagnosed with uterine and ovarian cancers 10 years later. Are they related, and did this drug become safer for use?
That's as far as I'm aware, there's no increased risk for ovarian or uterine cancer using medications like Clomid. Clomid's been around, like the reader said, forever. It's a very old drug. It's an inexpensive drug that we can use. It's pretty successful. And as far as I'm aware, it doesn't increase that risk for ovarian cancer.
We've had someone from New Jersey ask, I'm putting you on the spot here. I don't know if there's a website or a resource that you like that you send patients to when they're trying to get more information about proper vitamins, as they're starting to think 3 months ahead about getting in good shape to get pregnant.
There's no one particular website that I send people to. I do somewhat discourage people to, people will drive themselves crazy going on the internet and Googling things, and then all of a sudden they come in and they think they're dying. So I sometimes caution people to get a little bit, or if they get information from the internet and they have questions about it, that we're available to come in and talk to us, and that's what we're here for. Books like What to Expect When You're Expecting, those have a lot of valuable information, but you have to kind of use all of it kind of in conjunction with other things, and we're always more than happy to kind of answer questions and I guess bust myths like we're doing today.
Right. I mean, there is so much on the web. There's so much available. You could do all of your own research, and I'm sure that could be scary. What do you do? So what do you tell your patients to do? Do you tell them, listen, limit that?
I do. I try and, and it also depends on, every patient's a little different. Every person's level of anxiety is different. So sometimes, too much information, too much inaccurate information isn't a good thing. So I just try and encourage people to keep an open mind and to ask questions of us if they find something that doesn't seem right to them.
We have a question about someone who has a son who's 12, and she had a C-section with him, and she's asking, will she need another C-section if she gets pregnant again?
Not necessarily. We, at least at Abington, we are very much pro what's called VBACing, or vaginal birth after cesarean. So having had one prior C-section, you are certainly a candidate to attempt to VBAC. But when we talk about VBACing, kind of the two big things that we talk to patients about are risks of VBACing and then also likelihood of being successful, because who wants to go through labor and the whole process and then eventually end up needing another C-section anyway. So we oftentimes get information from patients as to why they had their C-section in the first place, and then kind of help counsel them about what their likelihood of success at trying to deliver vaginally after a C-section.
All right, here's a good one for you. Should men take vitamins to ensure healthy sperm? What do you think?
Ooh, I don't know the answer to that, actually. I know there's certain recreational drugs and things like that that can decrease sperm counts.
Okay, wait a second. Let's talk about that, because people are taking all sorts of crazy things over the counter, from health food stores. Yeah. what should you not be taking? What should be, someone told me, for men, being in a hot tub could be not a good thing. Is that true?
Well, there are certain
I
things.
know this is not your side of things, but.
Yeah, it's definitely not my area of expertise. In terms of, I try not to deal with men very much. My wheelhouse is only women, but marijuana tends to decrease people's sperm counts. In terms of the temperature of testicles and things like that, when things are very hot, it decreases sperm count. But beyond that, my knowledge of
Okay.
sperm and their likelihood of success is pretty minimal. I'll have to ask my my urology friends if they can speak to that, but I'm sure there's more to it.
All right. Yeah. Here's a question from Downingtown. Is it safe to take antidepressants while pregnant?
So that's a real hot topic, actually, because there are so many people that are on antidepressants, which are hugely helpful to people. There are some risks with being on antidepressants during pregnancy. There's potentially some risk of a cardiac defects in babies while moms are on an antidepressant during pregnancy. But again, everything in medicine is really kind of weighing positives and negatives, risks versus benefits. And I tell people, because a lot of people are really plagued with guilt. They're on an antidepressant because they're depressed, and is this going to harm my baby? But I tell people, if you are so incapacitated by depression and anxiety that you can't function, then what kind of how healthy can you be, and what kind of a pregnancy is this going to be for you, and what kind of how are you going to be able to exist, because there's two patients here, there's mom and there's baby. So if you get off your antidepressants and you can't even get out of bed, then that's certainly no way to live. So I encourage people to try and be on the lowest dose they can be, and then we'll do that additional testing, additional ultrasounds. We do something called a fetal echo, where we get a very detailed anatomy ultrasound of the baby's heart, and so you do those extra things in order to make sure everything's okay with baby. But it's a complicated situation. And there's always moms and guilt, and it's tough for people to really balance the two.
Right. All right. Here's a question. I am 40. And my husband and I had considered IVF. I had gone through many of the tests, but my doctors are telling me that I am very healthy. Our issues are male factor. If we use donor sperm and forgo IVF, how can I minimize birth defects that scare women at my age?
Gosh, it was a kind of a multifaceted question.
Yes.
But so donor sperm, I guess to back up, if your husband or your partner has issues with male factor, so their sperm, where they either isn't functioning properly or they don't have any, then donor sperm is definitely an option. You can do something called intrauterine insemination, where you take that sperm and inseminate it into the uterus, which the fertility doctors, that's sort of in their wheelhouse. So in terms of risks for birth defects and things like that, it's really no different than what your age would dictate and what the age of the sperm donor would be.
Okay. I'm being asked about something I don't. Maybe you can help me with, about saliva ovulation predictor, asking if it's easy to use and are you aware of its accuracy?
I'm not really so familiar with saliva ovulation predictor kits. I'm more familiar with the sort of traditional urine ones, and you basically the package comes with multiple dipsticks, and you pee on a stick for several days, and then once you get that second red line, then you know that you've ovulated. Sort of a funny story a personal story that when my husband and I were trying to get pregnant with our second pregnancy, we were doing the ovulation predictor kits, and we had them out. I was peeing on a stick every day, and then finally I thought I got that second line, and I'm looking and I can't tell, and it has to be the same color. If it's a little fainter, then maybe you didn't ovulate. So I go and I show my husband. I said, "What do you think? Is there a second line?" He says, "Is there a line there at all? Because you're colorblind." I was like, "You are no use to me at all." So, you know, it's one of those things where it's sort of those comical situations in your life. You just sort of roll with it. But I'm not very familiar with the saliva one.
I hadn't heard of it before. That's interesting if that's around, but I hadn't heard of it. You know, I think you mentioned earlier the risk of gestational diabetes, and you know, why is that more of a risk, and what happens? What is gestational diabetes, and what happens if you have that?
So gestational diabetes is basically diabetes that occurs in pregnancy. And some people come in to pregnancy already as diabetics, and they're in a completely different situation than a gestational diabetic. So normally in pregnancy, we would check someone for gestational diabetes between about 24 and 28 weeks of pregnancy. They drink a sugar drink and then get their blood taken an hour later. And depending on how they do on that screening test, if they fail it, they then move on to something called a 3-hour test, where they drink the drink and then get a series of blood tests done. If you are diagnosed with gestational diabetes, oftentimes we recommend a diabetic diet. And most people do very, very, very well on that, and their sugars are controlled with diet. They don't need anything further. Sometimes even despite people's best efforts with exercise and with eating the proper diet, their sugars aren't well controlled, and sometimes need to go on either oral medication or sometimes even injectable insulin.
Is that any predictor for whether that woman would get diabetes, or it's completely unrelated?
No, it is predictive. There's probably about 15% of women that have gestational diabetes then go on to develop diabetes when they're not pregnant. So in those cases where someone's diagnosed with gestational diabetes, oftentimes we'll recommend a follow-up test, usually 6 to 8 weeks at least postpartum, where we have them do a similar drinking that sugar drink and then getting their blood taken to test for diabetes. It's called a 2-hour glucose tolerance test, which we do postpartum.
Okay, and we've got a question in from Bucks County, and again, you can write in the text box underneath the video if you'd like to ask us a question right now. This question is it advisable to get my vaccination and immunity levels checked and possibly get vaccine boosters before trying to get pregnant? I think we've covered some of this before, but can you clarify for this viewer?
Sure. So one of the big things that we look for is your immunity to rubella. So people get their MMR shot as children, so it's immunity against measles, mumps, and rubella. So rubella is one that we that is sort of top on our priority list. So oftentimes it's always a good idea. You could get your titers checked and see if you're still immune to rubella, and then if you're not, then get vaccinated, get revaccinated with the MMR shot, because it's not something that you can be vaccinated for rubella once you're pregnant. It's not safe. So we'll check someone in their routine prenatal lab work. If they're not immune to rubella, then we note that, and they'll get vaccinated once they're not pregnant.
Another question from a viewer. I'm diabetic and take medicine every day. I've gained weight from a previous pregnancy and can't lose it. Is there a typical diet plan for women who want to get pregnant again and be lighter when ready for pregnancy? And again, are there more risks for a woman who's trying to get pregnant later in life and is diabetic?
So I don't know if there's a specific diet that we recommend. Certainly if she's already a diabetic anyway, then I'm sure she's had nutritional counseling, and if she hasn't, she should, as to the healthy, low carbohydrate diet that she should be eating as a diabetic. And what was the other portion of the question? I forgot.
Well, just, I guess, is she at more risk because she's diabetic? Does that add to?
Yes, so diabetics are definitely at a higher risk in pregnancy. They have higher complication risks, particularly if you have pre-existing diabetes, risks for having a larger baby, risks for, and sometimes even risks for babies dying later in pregnancy if they have very poorly controlled diabetes, issues with birth defects, with very, very poorly controlled blood sugars during the first trimester. So there's a lot of complications that can arise from being a poorly controlled diabetic. And I absolutely encourage anyone who comes to me and says, I'm thinking about getting pregnant, but I have XYZ medical issue. We send people for what's called preconceptual counseling all the time to our high-risk doctors, to the perinatologists, and they're a great resource for us. And they'll help map out a plan for the patient and kind of let them know how they can optimize whatever medical issue they have.
All right, here's another question. I'm age 41. I got pregnant naturally, but then had a miscarriage, and now we're trying again. I have so many things to worry about. I know there is a higher rate of abnormalities as time goes on, and wondering when I should start IVF, even if I got pregnant naturally about 4 months ago, due to my age.
Well, that decision to go to see a fertility specialist and proceed with IVF is obviously a very big and important decision for people. At 41, your age, your reproductive span is getting shorter and shorter. So we often tell people, honestly, excuse the expression, but not to futz around too long, because the time that they have to continue to be fertile sort of shortens and gets smaller and smaller. So, and when you talk to the infertility specialist, doing IVF in an older woman has a lot of advantages. They have a lot of means of genetic testing for certain embryos when you're beyond a certain age, or you have other pre-existing potential inherited disorders. And there's something called pre-implantation genetic diagnosis that they're able to do on these embryos, and they're able to determine the chromosomes and make sure that when they're doing IVF, they only put back the normal ones.
Okay. Dr. Thur, we're going to be wrapping up our health chat in a few minutes, and I thought maybe we go back and just review, if you're telling someone who's over 35, who's thinking about getting pregnant, again, what do you think are the most important takeaways for them?
I think that your approach to getting pregnant should be the same as if you were younger. It's just your that proverbial biological clock is ticking. And so it's not something where I would tell people to, attempt to try for, a year or 2 years on their own. And if they're not successful, I would come to see their OBGYN earlier so that we could start the process of the workup to see why they're not getting pregnant. And then, from there, once they are pregnant, just being aware of what's offered in terms of genetic testing and things like that to make sure that the pregnancy is healthy.
Dr. Mara Thur, thank you so much for being with us tonight, and we thank all of our viewers for joining us for this health chat that's sponsored by Abington Health in partnership with Philadelphia Magazine. And I want to tell you, to find more information on your specific health questions, you can go to www.abingtonhealth.org to find an Abington Health Center or hospital near you. On behalf of Abington Health and Philadelphia Magazine, I'm Lu Ann Cahn. I hope you have a wonderful evening. Thanks for joining us.